Thank you, Corey. Okay, now we're good here. So, it's a pleasure to do this and debate with Harvey. Harvey and I share one patient, and actually on my way here from the airport, that patient called me, and I didn't know that Harvey was going to be here until I walked in the room. So it was good. Those are my disclosures. Here's the problem with heterogeneity, with stage 3 disease, is that it's a very heterogeneous group of patients, as we know. And I'm not going to spend a lot of time focusing on this, but here's a patient with frank mediastinal infiltration. Here's a patient with discrete nodes that are enlarged, and whether they're single or multi-station affects our thinking. And here's a patient that has stage 3 disease, but it's clinically occult N2 disease, and you may not know it till you get the path report at that particular time. So, again, very heterogeneous. We all lump them under stage 3 disease, but it's a very heterogeneous group of patients, which is the major issue. And the different flavors that we think about in stage 3 disease, N2 versus non-N2 disease, these big local invasion tumors that don't necessarily have N2 involvement, the incidental or surprise N2 disease at the time of resection. I mentioned single versus multi-station N2 disease, and then N3 disease. And I think that many times when we talk to our colleagues in thoracic surgery, that the patients that the surgeons are often seeing and talking and thinking about are often very different than the patients that end up in the med-onc and rad-onc. In reality, we should be discussing all of these patients in a multidisciplinary fashion to get to a consensus in terms of their management. I would argue that perhaps this is surgical disease. Incidental N2 disease is surgical. We know there's a role for adjuvant therapy here. I think we would all agree, I think the panel in the last session agreed that N3 disease is non-surgical, and that's chemoradiotherapy disease. We struggle with this issue about single versus multi-station disease and often have lots of arguments about the best way to approach these sorts of patients. Well, this is, I always love this. This is a very old reference, but it kind of brings home the point about where our staging system fails us. These are all stage 3A N2 disease patients. So we think of them all in this category, but you see there's a tenfold difference in long-term outcomes with surgical resection. And what you have here are minimal N2 disease in a single station, doing the best, and then those clinical N2 disease that are multi-station actually doing very poorly with surgery. So this is the heterogeneity of the patients we see simply with N2 disease, and our staging system doesn't account for that, but we all talk about this. These are probably more the patients that the surgeons are seeing. These are probably more the patients that the med-onc and the rad-onc are seeing. So, and then it gets to the endpoint of greatest interest, which I think is overall survival, long-term survival. There's little nobility in controlling intrathoracic disease if you die of brain mets. You say what do you say to the family? Thank God it didn't recur in the chest. I mean, it just doesn't make any sense. So overall survival has to be the primary endpoint in this setting. So being asked to take the bimodality approach, does chemotherapy offer a chance at cure or long-term survival? Well, here are the two, I actually showed you, this is an older slide that I used, but I did show you the RTOG experience. But here's an older RTOG experience. I mentioned before the BLP vaccine trial that was called the START trial, and here's the long-term outcomes with either sequential or concurrent therapy. And you see that there is a tail on these curves, and how I think about this in my practice is that probably around 20 to 25% with modern chemoradiotherapy, they get to that 4 or 5 year survival point and are seemingly free of disease. And I will remind you that these trials included a mixture of 3A and 3B. So much of this was N3 disease. About half the patients in both of these trials were probably N3 disease, although I can't remember off the top of my head. Has chemoradiation improved? Well, we talked about that, yes, before. Concurrent better than sequential. We've adopted that over the past couple of decades. I've discussed this point. We have lots of options with not one that is superior. I think the biggest change has been in radiation therapy, both in imaging, so identifying the target, in the technology, which is to be able to deliver the dose to the target, and also the technology to spare normal tissue. Remember, the toxicity of radiotherapy is not necessarily related to the total dose of radiotherapy given. It's related to an excessive amount of a normal organ getting an excessive dose. So if you limit the dose to normal organ, you can actually push the dose. And we're all familiar with what SBRT and gamma knife strategies can do in terms of delivering a high dose to a relatively confined area. So we've seen improvements in that setting. So with that as a standard, do we have evidence that offering surgery in stage 3A disease can improve the chance of cure or long-term survival? Here's the data again from the last CHEST update. I don't know if there's been any data since this particular time, but we have the two trials, Albane done in this country and Van Meerbeek done across the Atlantic in the European arena, both 350 to 400 patients here or so, that isolated this question of surgery either after induction chemoradiotherapy here or after just chemotherapy alone. And then a couple of smaller trials here looking at that. And we look at the two overall survival in the two largest trials here. Really no difference in long-term outcomes. This was chemoradiotherapy induction followed by surgery versus chemorads alone here, and this was chemo alone followed by surgery, or actually, this actually was done with sequential chemoradiotherapy. So it was chemo followed by radiotherapy as a single modality, no concurrent there. So you see these are the outcomes from these two trials. No difference. Now, we often hear arguments, and I love this. This is something Frank Detterbeck put together. His name comes up often with these guideline things, but you often hear, well, it's minimal N2, it's a single station, only clinical N01 disease, non-bulky nodes, however people define that, good surgical risk, risk downstage, tumor shrinkage, lobectomy versus something else, pneumonectomy. And really, in this, at least in this guideline thing, it's really unclear that these are justifications for surgery because the data is just not there. Now, one of my pet peeves is this unplanned retrospective analysis. See, Corey gives me a podium, and I have to bring this up because often we say, well, if you can get a lobectomy, that you'll do better if you incorporate surgery. And so after the Albane trial was negative for surgery, a retrospective unplanned subset analysis was done looking at the difference between lobectomy and pneumonectomy. To me, this is a little bit dangerous. The matching criteria were age, sex, and T-stage. And in the trial, when you look at the trial, the most important thing was nodal clearance. Of course, nodal clearance by induction chemoradiotherapy is only diagnosed by the surgery. It's not caused by the surgery. It's a marker of chemosensitivity. You couldn't match that because the chemorads patients, you didn't know if they had nodal clearance. And that was the most important prognostic factor. Again, no information on rates of nodal downstaging, response to induction therapy given. In my opinion, this should not be used to make any clinical decisions about whether surgery should be incorporated or not. So, the problem with stage 3, my conclusions, it's a heterogeneous group of patients where one size does clearly not fit all. Chemoradiotherapy represents the standard of care in most situations. There's certainly no level 1 evidence supporting the routine use of surgery in the N2 subset. Now, having said that, I think there are potentially patients that may benefit from surgery, those that have nodal clearance and have persistent treatment-resistant cells in the primary. And this gets us back to, again, going back to the Albane trial, looking at patients who were pathologically downstaged. Again, this pathologic downstaging has nothing to do with the surgery. Surgery detects it, but doesn't cause it. This is probably a surrogate marker of chemosensitivity. And if we could identify those patients that still have tumor bulk tumor in a lobe or a lung or whatever, and those patients, to find that subset, I haven't given up that surgery could be important in selected patients, but as an accepted paradigm, I have to argue against it. So thank you.